You're listening to the Assembly on Pulmonary Circulation podcast, brought to you by the American Thoracic Society.
All right, welcome to another episode of Practical pH. I'm Katherine Cox-Flaherty, a pulmonologist at Inova Fairfax Hospital.
And I'm Khushboo Goel, a pH specialist at Cedars-Sinai. We're continuing our Foundations of pH series. In the first two episodes, we discussed the diagnostic approach to pH, followed by how we risk stratify patients with pH. And today we'll be discussing the newest hemodynamic definitions of pH, which were introduced in the 2022 ESC/ERS guidelines, and also by the 7th World Symposium on pH. We'll also be delving into additional testing that can be done during a right heart cath to better elucidate what type of pH our patient has.
We're lucky enough to be joined by Dr. Ryan Tedford, who is a professor of medicine and cardiology. He's the section head of heart failure and the medical director of cardiac transplantation and the director of the Advanced Heart Failure and Transplant Fellowship Program at the Medical University of South Carolina. He's an internationally recognized leader in the field of heart failure and pulmonary hypertension. Thank you so much for joining us on the podcast.
Katherine and Khushboo, thanks so much for having me. Look forward to a good discussion.
Thank you. So we always like to start our episodes by asking our guest how they became interested in pulmonary vascular disease. So how did you get involved in pulmonary vascular disease, and what excites you most about this field?
Well, thanks for asking that question. I was a cardiology fellow at Johns Hopkins, and I was looking for a research project. And I met with David Cass and Paul Hassoun, and they told me about a project they had going on where they were trying to understand why patients with scleroderma-related pulmonary hypertension had worse outcomes than other forms of pulmonary hypertension. And they had a hypothesis at that time that proximal pulmonary artery stiffening increased RV afterload, and perhaps that underscored why these patients did worse. It turns out that that hypothesis was completely wrong. But I did accept the project, and I got moved into leadership of that project. And we made some really novel observations about the relationship between resistance and compliance in the pulmonary vasculature, and some insights into scleroderma myocardial involvement, and also how to assess RV function. So that was kind of my intro to pulmonary vascular disease. And then given my clinical interest in heart failure and transplant, then a lot of that interest migrated to group 2 pulmonary hypertension.
Wonderful. So today we're hoping to discuss hemodynamic assessment of pulmonary hypertension. And, we touched on this a little bit on our previous episode, but do you mind just sort of briefly sharing why you think hemodynamic assessment is essential for these patients?
Absolutely. Well, it truly is the gold standard. And of course, pH is a hemodynamic definition. Now, echo is an excellent screening tool, and we use this regularly to screen patients who are at risk for pulmonary hypertension. But we do need to understand the limitations. We can both overestimate and underestimate the severity of pulmonary hypertension. And we also have to remember work from Evan Britton and colleagues at Vanderbilt showed us that about 20% of the time, at least in the referral population, pH can be present even without a tricuspid regurgitation jet. So we always have to maintain a high suspicion, particularly in patients with severe symptoms, RV dysfunction, or risk factors for pH, for example, patients with scleroderma. It is also, of course, very important to determine the pretest probability of pH and the presence of left heart disease whenever we're considering someone with pulmonary hypertension. But it really does come down to the hemodynamics. We have to confirm the presence of pulmonary hypertension. And of course, then we differentiate pre-capillary from post-capillary pulmonary hypertension through the right heart catheterization, through hemodynamics, completely divergent treatments, as you all are aware of. But we have to make sure that the right heart catheterization is done the right way. It has to be done carefully and meticulously to make the diagnosis right.
Absolutely. I think it's a really important message that we really want to reemphasize and underline. So thank you for that. Now, like we normally do, why don't we just start off with a clinical case? So we have a 58-year-old woman with systemic sclerosis who's had progressive dyspnea with exertion over 6 months. She has a clear CT chest, negative VQ scan, normal pulmonary function tests, except for an isolated, mildly reduced DLCO. Her echocardiogram is technically challenging, but suggests right atrial and right ventricular dilatation, reduced TAPC, elevated TRV, and an estimated pulmonary artery systolic pressure of 55. So what do you think is going on, and what would be your next diagnostic step?
Great. Well, clearly this lady has a high pre-test probability of having pulmonary hypertension, right? She has risk factors for it with her scleroderma. She has evidence of RV dilatation and dysfunction, as well as right atrial enlargement, and clearly a very elevated pulmonary artery systolic pressure estimate, at least. And so going into the right heart catheterization, we're going to suspect or find pulmonary hypertension. Now, she is at risk for several pH subgroups. Now, we've effectively ruled out groups 3 and 4, right, with the normal chest CT, the normal PFTs, and a negative VQ scan. But she's still at risk for having group 1 and group 2 pulmonary hypertension. We know that patients with scleroderma can have left heart involvement, and that can be significant. Now, there's no comment on some of the left-sided parameters here on the echo, which is very important, right? We want to know what her left atrial size is. We want to know what her LV looks like. We want to know if she has valvular disease. But the right heart catheterization will certainly help us sort this out.
Perfect. So how do you counsel patients when you talk to them about going through a right heart cath? What kind of risks do you talk to them about? And are there any contraindications you think about as well?
Sure. Well, I usually start by telling my patients of all the procedures we do back in the cath lab, this is probably the safest, particularly in expert hands and in expert centers. That being said, there are risks with any procedures. We take several steps to mitigate those risks. For example, I use a micro puncture needle, and I tell them the key part of that word is micro, meaning very small. And so there are subtle risks of bleeding, damage to the artery, but we try to mitigate that with using ultrasound-based access, as well as that small micropuncture needle. There's risks of arrhythmias or extra heartbeats. About 1 in 1,000 times we have to give a medication or to do another procedure to get the patient back in regular rhythm. We talk about the risk of infections exceedingly low with our sterile techniques that we use. We talk about their mild radiation exposure. Most of the time, we don't even need fluoroscopy to do right heart catheterization. Sometimes we do. And we talk about the small risk of pneumothorax, which is yet to happen to me, and don't want to start with those patients. And a very small risk of things like PA rupture. But again, in expert hands, this is a safe procedure. It's one that is really required for diagnosis and treatment. And so I think it's certainly the benefits outweigh the risks most of the situation. In terms of contraindication, there's not a lot. We will do right heart catheterizations on patients who are fully anticoagulated if the risks of stopping anticoagulation outweigh the benefits. For example, patients with an LVAD will typically continue with the warfarin. Patients who have hypercoagulability, we will sometimes do that as well. We try not to do it on NOACs. We prefer warfarin since it's reversible. But those are some of the contraindications. We have to be careful in patients who have had tricuspid valve interventions, just to make sure that we don't damage the structure there. And then, of course, people that are pregnant, we want to minimize any radiation exposure. But in general, a very safe procedure with few contraindications.
Great. So, as you've discussed with your patient, they agree with moving forward with the right heart cath, and her right heart cath is notable for a right atrial pressure of 10, RV pressure of 70/10, mean PA pressure of 42, pulmonary capillary wedge pressure of 11, and we'll call this indirect FIC cardiac output of 3.8 liters, which results in a PVR of 6.5 Wood units. So with these numbers, how would you classify her pulmonary hypertension?
Sure. Well, I guess since you specified indirect FIC, we try not to use an indirect FIC, as folks are keenly aware. Our guidelines remind us that thermodilution is the preferred methodology if we cannot measure a direct FIC. And that's because our VO2 estimates are simply poor in patients with pulmonary hypertension and heart failure. Now, in the MUSC Cath lab, we have a metabolic heart, so we can measure direct FIC. But in the absence of that, thermodilution should be used even in the setting of significant tricuspid regurgitation or low cardiac output. The one exception is an intracardiac shunt, where we would prefer to use an indirect FIC. That being said, it looks like these hemodynamics were done very well. The wedge pressure is in the normal range for this patient. We don't have to confirm with a wedge saturation because the wedge is in the normal range. And so at least based on these numbers, this is a pre-capillary pulmonary hypertension phenotype. Again, I want to know a little bit more about risk factors for left heart disease. Is there left atrial enlargement? Sometimes we'll look at the amount of respiratory variation we see as well. If there are risk factors for left heart disease, it may be someone I will want to consider doing provocative testing on. But so far, based on what you've told me, this is a pre-capillary phenotype.
And do you mind, just for our audience, going through the hemodynamic definitions for pre, post, and combined CPCH?
You bet. As many folks are aware, our definitions have changed significantly over the past 5 to 6 years. First, reducing the threshold for pulmonary hypertension. Brad Marin and colleagues showed us, based on two large registries, that risk associated with mean pulmonary artery pressure actually begins much earlier than we previously knew, and does so just above a mean pulmonary artery pressure of 20. And so the new definition of pulmonary hypertension is a mean pulmonary artery pressure greater than 20 millimeters of mercury. We then get into subtypes of pulmonary hypertension. And in patients who have left heart disease, which we define at rest at least by a wedge pressure greater than 15, we can subdivide them into isolated post-capillary pulmonary hypertension or combined post and pre-capillary pulmonary hypertension based on the pulmonary vascular resistance. This threshold has also changed recently, again, based on work that Brad and I and others did, which showed that risk, again, of mortality began at a PVR earlier, around a threshold of 2.2 Wood units. But our definition now states that combined post and pre-capillary pulmonary hypertension is a PVR greater than 2 Wood units, where isolated post-capillary pulmonary hypertension has a PVR of less than 2 Wood units. This has led to a significant increase in the number of patients who meet the criteria for CPCPH. In fact, in referral populations, based on some French registry data, it can be as high as 70%. It's clearly not that high in the community. It's probably closer to 30%. But it does certainly recategorize the number of patients based on that threshold. And then, of course, just for pre-capillary pulmonary hypertension, this is also the threshold we use now, rather than a PVR of 3, a PVR of 2 Wood units.
Yeah, and so I think, in addition to just capturing more patients now who are going to be diagnosed with pulmonary hypertension, I think it's also opened up a new question for PH specialists, which is, how do we approach patients with precapillary PH who have a mean PA pressure between 21 to 25 and a PVR of 2 to 3? The 2022 ESC ERS guidelines, they made a point of stating this caveat that most PAH specific drugs were studied in patients with the prior definition of a mean PA pressure greater than or equal to 25 and a PVR greater than 3. And so can you share your approach to patients who fall in this category of a mean PA pressure between 21 to 25 or a PVR 2 to 3? And second, are there more formal guidelines or a consensus of expert opinions on this matter for anyone who might be treating PH patients?
Sure. When the definition was changed, it was made very clear that the reason for changing was based on normative data and associated risk. And so these are the thresholds at which risk begins. That doesn't necessarily mean or doesn't necessarily follow that this is where treatment should begin. We also know that our measurement techniques are imperfect. And so there is error associated with, for example, even thermodilution cardiac output, right, or assessment of pressures. And so there is going to be some imprecision in these kind of borderline pressures and borderline resistances. So it was kind of reiterated at the Seventh World Symposia that we don't really have data to support treating in this threshold. And so there's no specific recommendation to do so. In general, I think these are considered on a case-by-case basis, and it depends a little bit on the scenario, the risk factors, what the RV looks like. So, for example, if you have a patient with scleroderma, again, known risk factors for group 1 pulmonary hypertension that has a borderline dilated right ventricle and is highly symptomatic and a PVR of 2.8 Wood units, this might be someone that we want to think about treating. On the other hand, if you had somebody who had a PVR of 2.1 and just was referred because of an elevated RVSP on echo with no symptoms and normal structural heart, that's probably not somebody that we would need to think about treating. But I think it is an individual case-by-case decision when we approach these patients with more borderline hemodynamics.
Great. Thanks for sharing your insight in kind of this gray area. We'd be remiss to have you as our guest and not pick your brain more about some of the nuances of right heart cath. So if it's okay, we'd like to ask a few more questions about sort of additional provocative maneuvers, which can be done during a right heart catheterization. But first and foremost, would you mind talking us through what vasoreactivity testing is and when you do it? So for example, in the case that we presented with scleroderma, should she have undergone vasoreactivity testing? Appreciate your thoughts.
Absolutely. Well, first of all, give a shout out to Mark Belkin and Murat Budin, who recently put together a very nice consensus statement published in Circulation Heart Failure from the AHA and ACC, talking about the role of provocative testing in patients with pulmonary hypertension and heart failure. It's a really nice statement, so I'd encourage you all to take a look at that. I was grateful to be a part of that. In this specific case, right, we think this person has group 1 pulmonary hypertension. Although, because they have connective tissue disease, vasoreactive testing is actually not technically indicating this person. So when is it indicated? Well, it's indicated for patients who have idiopathic anorexigen-associated or inherited pulmonary hypertension only, and that is really because a positive vasoreactive response does not predict response to monotherapy of calcium channel blockers in other populations. So it's really only in this population. And in fact, these patients probably have a completely different physiology. And at the 7th World Symposia, they were actually given their own classification because of this. We also know their prognosis tends to be better. Now, when we do provocative testing, that can be done traditionally with inhaled nitric oxide or inhaled prostacyclin. There are some other drugs that can be used, like adenosine. What we're looking for is for patients to lower their mean pulmonary artery pressure to a level below 40 millimeters of mercury, and by at least a drop of 10 millimeters of mercury, while maintaining or increasing their cardiac output. And again, we don't do this to determine if they're going to respond to PAH-specific drugs, simply if they're going to be responsive to monotherapy calcium channel blockers, and also, again, portends a better prognosis. And so that is the traditional, testing that we would do in the cath lab for somebody with precapillary pulmonary hypertension. Now, we talk a little bit about other challenges that we might do, and I think we'll get to speak a little bit more about that in a minute. But we could think about, for example, in patients with risk factors for left heart disease that have hemodynamics consistent with precapillary pulmonary hypertension, we can do things like a leg raise. We could do things like a fluid bolus, or perhaps even exercise if our pretest probability of left heart disease is high enough.
Absolutely. And actually, that was going to be my next question, was the fluid challenge, because I think that's really important, like you said, in teasing out diastolic dysfunction. And I think a common theme that we're getting into is that we have to have a really good pretest probability of A, is our patient going to have pH, and B, what type of pH, so that during the cath, you know when to pull the triggers depending on the numbers that you're getting. And so when you do a fluid challenge, whether it's giving a bolus or doing a leg raise, can you talk us through the details for exactly how you interpret the results?
Absolutely. And Khushboo, I think your point is really critical. And I always tell my trainees, my fellows, you have to know what you're going to find before you go into the cath lab, right? So if something doesn't fit, you have to be able to explain that. And if you haven't looked at the echo, if you don't know the patient's history, then you're not going to know the pretest probability, and you're not going to know when the provocative maneuvers are indicated. So, the two that are the simplest are the passive leg raise. And of course, when we do a passive leg raise, we're increasing venous return to the heart. So it's essentially like giving a fluid bolus. And when we do this, if we see the pulmonary artery wedge pressure increase to a level of 19 or above, this is highly suggestive of left heart disease. We have now a couple studies, one that we recently published and one published by the group in the Netherlands that showed us that the positive predictive value wasn't quite good. Now, in the initial study by the group in the Netherlands, they also showed that if your wedge pressure stayed below 11, that this effectively ruled out the presence of left heart disease. We actually did not find this in our multi-center collaboration with the group in Milan, where there was the negative predictive value was not as good. But I think if you do the leg raise and you see that wedge pressure go above 19, again, highly suggestive of left heart disease. The fluid bolus probably has a little bit more data. We typically will give 7 to 10 mg per kg, or milliliters per kilogram, which in most patients is around 500 cc's. And we do this over 5 minutes. I used to actually put a pressure bag over a saline and try to infuse that through the side port. But what I actually found works much better is actually just taking a 60 cc syringe, filling it up to 50 cc's, and inject it every 30 seconds for 5 minutes. And then I've given the patient 500 cc's. It's a very similar threshold. So I'm looking for a wedge pressure that goes to 19 or above that would be suggestive of left heart disease. Now, I'm certainly not advocating for a fluid bolus under other situations, for example, patients with unexplained dyspnea, because I think our data for that is very little. This is really specifically to differentiate group 1 from group 2 pulmonary hypertension, where I think it can be very helpful. And frankly, it can be done in any cath lab. It doesn't require specialized equipment, and it's relatively easy to interpret. So those are that's really kind of high approach. The leg raise and the fluid challenge, I think both are very useful tools in the right clinical setting. Again, if we see that pretest probability is high for left heart disease. I guess maybe I'll conclude that with just saying, despite this technique and what we think is probably better phenotyping, patients didn't receive fluid challenges and they were enrolled in clinical trials of pH drugs. And so what to do with this information is a little bit uncertain. If someone were to treat those patients with pH-specific drugs, it's recommended that they monitor for side effects and very close follow-up due to the probable presence of left heart disease. But again, those patients weren't necessarily excluded from clinical trials.
Great. Pivoting a little bit, do you mind also talking about whether you always or how you decide when to do a shunt run, what a shunt run is?
Absolutely. I don't always do a shunt run, but I always measure 2 saturations. And the first saturation is just with the venous sheath in the jugular vein, and I'm measuring an SVC saturation. And then, of course, I'll be measuring the mixed venous saturation in the pulmonary artery. So why do I check an SVC sat every time? Well, several reasons. One is I'm going to get an immediate assessment of the perfusion status of the patient. So if I have my sheath in and the SVC sat comes back at 25, I'm going to say, oh my goodness, this patient has very low output. I need to make sure that I'm paying close attention to how they're doing during the procedure. By looking at the difference between the SVC sat and the pulmonary artery saturation, I'm going to be understanding if there's a potential for a left or right shunt. So typically we talk about a step up of at least 10% that would make us suspicious. Now you might say, well, I guess classically it's thought if you see a mixed venous sat above 80%, that you should suspect a shunt, and that's certainly true. But if you don't check an SVC sat, you can actually miss cases. We certainly have seen patients who have very low cardiac output, and therefore, even though there is a left or right shunt, their mixed venous saturation is not all that high. It could be 60%. Without the shunt, maybe it had been 40%. And so always measuring the SVC sat will prevent you from missing potential left or right shunts. When I do suspect a left or right shunt, then I'm going to move in and do my full shunt run so I can hopefully locate the region of the shunt, and then I can confirm later on imaging. But I think this is a practice that is not always common to check an SVC sat and a mixed venous sat, and something I recommend to be done with every right heart catheterization.
Absolutely. And I know it's always a little difficult to discuss right heart caths in an audio platform, but do you have any cautionary tales or recommendations when it comes to waveform interpretation? You already really touched upon another important point, which was, cardiac outputs and direct fic and thermodilution and indirect. But specifically when it comes to looking at the report and waveform interpretation, depending on the institution, the PH specialist may not be the one doing the right heart cath, but they still need to make decisions based off of the cath report, and hopefully their own review of the waveforms, because depending on the numbers you get, that's going to really wildly change how you treat that patient.
Absolutely. I could probably speak for an hour about this. But I think what you mentioned there about reviewing the waveforms is absolutely critical. And when I report in my reports of right heart catheterization, I try to give the referring the most information possible if they didn't have the waveforms actually to review. Now, in most patients, we will be measuring our pressures at end expiration. That's where we believe that intrathoracic pressure has the least impact on these measurements. Turns out that's not true for everybody. For patients with significant interstitial lung disease and perhaps those patients who are morbidly obese, at least in some situations, this might overestimate our true pressures. But again, in most people, we're going to be trying to measure at end expiration, which in general will be the highest point in the respiratory cycle, unless somebody's on positive pressure ventilation. There are situations, however, where, again, patients have significant respiratory variation, like interstitial lung disease, like morbid obesity. In those situations, averaging over the respiratory cycle may be more appropriate. If you look at the World Symposium recommendations for lung disease, it's actually taking that average pressure over the respiratory cycle. Now, you never actually have the patients do a breath hold. We know as patients do a breath hold, they start the Valsalva, and this will reduce preload and will impact your pressure measurements. So we would take a running average. What I typically do when we see patients have significant respiratory variation, say, for example, 10 millimeters mercury or more, I'm going to report both. I'm going to report both the end expiratory as well as the average over the respiratory cycle. Again, giving all the information I can to the referring provider. Measuring the wedge pressure is really, really critical, and how we measure the wedge pressure is going to impact the diagnosis. In general, we're trying to, and it really depends on what you're trying to learn from the right heart catheterization or what you're trying to learn from the wedge pressure. The end diastolic wedge pressure is going to closely approximate left ventricular end diastolic pressure, because essentially at the end of diastole, there's an open system between the pulmonary vein, the left atrium, and the left ventricle, because all the valves are open. Now, there are situations, however, when patients have a very stiff left atrium or they have mitral regurgitation, they have very large V waves. And in that situation, that V wave is actually contributing to some of the elevation in pulmonary pressures. And so in that situation, the mean wedge pressure, which incorporates all waveforms over the cardiac cycle, is actually going to be higher than the end diastolic wedge pressure. I find the mean wedge pressure more appropriate when we're calculating pulmonary vascular resistance, because I'm essentially trying to understand resistance within the pulmonary circulation if I took away the heart. So I want to get rid of the contribution of those V waves. And that gives me a better sense of what that true capillary component is. But the wedge pressure can be somewhat difficult to interpret. One of the things that's very critical, particularly if the wedge pressure is elevated, is to confirm that you're truly in a wedge position. That means that you have completely occluded the pulmonary artery with the balloon, so that what you're measuring is actually an estimate of left atrial pressure. The easiest way to do that, even in patients that it looks like you're wedged by fluoroscopy or by typical waveform, is by measuring a wedge saturation. So we draw back blood from the distal tip of the catheter with that balloon inflated. After a few cc's of blood, typically the blood will start to turn bright red, and the oxygen content of that blood will approximate that of the systemic circulation. We know then we're fully occluded, and what we're measuring is an estimate of left atrial pressure. If the balloon is not fully occluded, you'll have deoxygenated blood going past the balloon, and in that situation, the blood content, the oxygen content of that blood will not approximate the systemic circulation. At that point, you should drop your balloon, you should try to reinflate it and get a better wedge pressure. A simple maneuver like that can really prevent you from making significant error in your diagnosis of pulmonary hypertension. We actually prospectively studied this, which we published a few years ago in Circulation Heart Failure, and shown that 50% of the time when a proceduralist felt that they had a true wedge pressure, they were unable to get a wedge saturation that approximated that of the systemic circulation. But with up to 3 subsequent attempts, 90% of the time that could be done. And the final wedge pressure during these attempts were lower, and therefore the PVR was higher, leading to a net reclassification of 12% of patients. So again, a very simple technique we can use to improve our precision with these measurements.
Great. Thanks so much for those tips. And finally, I know this is a sort of a huge topic in and of itself, but we'd love to briefly touch upon exercise testing. Can you share how you sort of approach the decision to perform an exercise right heart cath, and the ways in which it can be done?
Yeah, great topic for discussion, maybe deserving of its own podcast.
Yes.
But exercise is an extremely useful tool. We do invasive CPET testing here at MUSC. We do both supine and upright in certain situations. Exercise is complicated. And if you poll the so-called expert centers around the country, all of us do it a little bit different. But I think there's some themes that are quite important. One is that bicycle ergometry is really the preferred methodology to exercise. The days of using saline bags and isometric exercises is not appropriate for provocative exercise testing. Now, whether or not you do it supine or upright, I think is preference. Certainly, those that do it upright typically have more staffing. It takes a little bit longer, particularly until you get good at it. And it may be different questions you're trying to answer with that provocative testing. There's still no consensus about which is the most appropriate position, the duration of exercise. Do we need to do maximal, submaximal? How to actually measure pressures during the respiratory cycle during exercise is still complicated. Our pressure swings can even be more than at rest. What really constitutes normal from abnormal, it's still not all that well defined when it comes to left heart filling pressures, at least. We have a couple of different metrics we use. We have absolute wedge pressures of 25 with supine exercise and 20 with upright. We can look at wedge to cardiac output slopes, being greater than 2 being abnormal. That can be used. But there's still a lot of uncertainty, and interpretation is also difficult during exercise. These are fluid-filled catheters. There's a lot of catheter ringing that occurs that can make particularly measuring the systolic and diastolic pulmonary pressure difficult because of that catheter ringing. But in the right hands, it can be a very useful test. Now, it can be used to differentiate group 1 from group 2 pulmonary hypertension. I personally find the fluid bolus and or leg raise to be easier and more straightforward and easier to interpret and less resource intensive. It's also somewhat difficult to get a bicycle on the table when the patient is already there. So if you hadn't prepped for exercise, it can be difficult to do. But exercise can be helpful, I think, most certainly in patients with unexplained dyspnea, where we're looking for abnormal pressure flow slopes. We now define exercise-induced pulmonary hypertension by the mean pulmonary artery to cardiac output slope greater than 3. This is an abnormal response. This changed from years ago where we used to just define exercise pulmonary hypertension by simply a mean pulmonary artery pressure greater than 3 Wood units or greater than 30 millimeters of mercury. We learned that patients over the age of 50, half of them actually had an abnormal mean pulmonary artery pressure greater than 30 because we weren't accounting for flow. And so that's why we have to account for flow with those pressure changes. But again, it can be helpful to diagnose, for example, exercise-induced left atrial hypertension or exercise-induced HFpEF. Some situations of exercise-induced pulmonary arterial hypertension. We can also diagnose preload insufficiency via these metrics. So it can be a useful tool, but I would just caution folks that either not used to doing this or comfortable doing them, or if they haven't done a lot, there can be a lot of mistakes made. There's been a number of times, for example, that I get referred patients for exercise-induced pulmonary hypertension, where their PVR went from 1.5 at rest to 8 with exercise. And when you look at the data, their cardiac output went down from 6 to 1. And of course, that's not physiologically possible. What was done is they used an indirect vector in exercise, which of course you can't do because VO2 increases significantly during exercise. But these type of kind of mistakes can happen if you're just not familiar with this type of testing. So I think best left to expert centers under certain situations, particularly unexplained dyspnea. For differentiating group 1 versus group 2, I really stick to leg raise or fluid bolus.
Great. And sort of maybe a loaded question, but for exercise-induced PH, how do you approach treatment? Do you always treat it?
Yeah, so I have to admit my practice these days is predominantly left heart disease. So that's one that I'll refer to my pulmonary colleagues, Dr. Argula and Dr. Sese. When I see someone who develops exercise-induced pulmonary arterial hypertension, so their wedge pressure is staying low, the first thing I think about is actually CTED. And so I make sure that I have not missed a case of CTED. And I would say, almost half those cases, that's what I actually find. There certainly are situations for, again, patients with connective tissue disease that we might consider, especially maybe if that PVR was in the borderline range. But I usually will leave that up to them. And certainly we don't have a lot of good data in this area to think about whether and how to treat those patients. If they have exercise-induced left atrial hypertension, we think about treating the underlying heart failure condition, for example, with SGLT2 inhibitors, perhaps with non-steroidal MRAs. And then there's a lot of clinical trials that can be, those patients can be enrolled in.
Great. Well, like I said, I think we can always talk about this for much longer, but we really, really appreciate your time and your expertise. I think really hit upon a lot of high yield topics. And I think another message is, right, for anyone who's treating PH patients, we really want this to be a collaborative effort between, people treating patients in the community with PH expert centers, because like you've shown us and really told us that just doing the cath alone, there's a lot of nuance that goes into it, both doing it and interpreting it. So thank you so much.
Well, that's well said, and thank you very much for the invitation.
Awesome. And to our listeners, just stay tuned for our next episode of Practical PH. We'll be doing a preview about ATS 2026, and we'll be highlighting all the pulmonary circulation sessions that we can look forward to. So with that, we'll tune into the next episode. Thanks, everyone.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more podcasts from the ATS assemblies on YouTube. Don't forget to like, comment, and subscribe so you never miss a show.